So returning to our case in the context of the recent update of the CheckMate 214 study, we know that this patient had poor risk disease using the IMDC criteria. He received induction ipi/nivo and achieved a partial response. He then went on to receive 6 months of maintenance nivolumab followed by progression, at which time he was transitioned to cabozantinib. An update from the CheckMate 214 study was recently published in the Lancet Oncology in the past few months. This included a median follow-up of over 30 months. The CheckMate 214 study, recall, compared the combination of ipi/nivo to sunitinib, primarily in intermediate and poor risk patients. With this longer follow-up, it was confirmed that the overall survival in the ipi/nivo arm was superior to the sunitinib arm in the intermediate and poor risk patients, as in our case. The median overall survival in the ipi/nivo arm was not reached, compared to over 26 months in the sunitinib arm, with a hazard ratio of 0.66. The response rates also favored the ipi/nivo arm. The overall response rate was 42% in the ipi/nivo arm, with an 11% complete response rate, compared to 29% overall response rate in the sunitinib arm, with a 1% CR rate. The median duration of response in the ipi/nivo arm has not yet been reached, compared to 18 months in the sunitinib arm. So, putting our patient's experience in the context of these updated results from CheckMate 214, we know that our patient initially achieved a partial response, as 40% of the patients in 214 did. However, because our patient progressed at the 9-month mark, his progression event was earlier than the median that's been shown thus far in 214. So after patients progress on frontline therapy, most of whom are now receiving an immune checkpoint inhibitor regimen, the key decision, I think, that influences what to use in the second-line setting is really based on their frontline therapy. If a patient has received an immune checkpoint inhibitor in the frontline setting, as most are doing now, I think that the preferred regimen in the second-line setting should be TKI-based. Prior to the availability of immune checkpoint inhibitors in the frontline setting, we had the option of nivolumab versus changing to an alternate TKI in the second-line setting, but I think that decision is less relevant today, given the fact most patients are receiving immune checkpoint inhibitors up front. When considering TKIs in the second-line setting, the two most utilized regimens now that are supported by Category 1 recommendations within CCN include cabozantinib monotherapy or the combination of everolimus and lenvatinib. So I think today the primary consideration is between those two regimens for patients that have failed immune checkpoint inhibitors. For that matter, however, for the select patient that still receives TKI monotherapy in the frontline setting could be considered for an alternate TKI or perhaps an immune checkpoint inhibitor. But the real decision today commonly is what to use following immune checkpoint inhibitor and how best to select between either cabozantinib or the combination of lenvatinib and everolimus. So when considering between cabozantinib and len-evro, there are two key points that influence my decision, and I tend to use cabozantinib primarily in the second-line setting. Those 2 points are the strength of the evidence. The trial, as I mentioned, that led to the approval of cabozantinib is a large phase 3, so level 1 evidence, compared to a smaller phase 2 for lenvatinib and everolimus. And anecdotally, and based on the adverse event profiles that were reported in both of the respective trials, I find that cabozantinib monotherapy is generally better tolerated than lenvatinib and everolimus combination at the approved dose. So the strength of the evidence and the underlying tolerability lean me to use cabozantinib most often in the second-line setting.